Hello, everyone, and welcome to the Menocare Report. We are back, everyone. We finally have a new podcast episode for you guys, and today we're going to have an amazing discussion about endometriosis in the Black community. I hope you're ready. This is going to be really interesting. Get your pens and your papers ready because we're going to teach you some things that you didn't know before.
Hi there, I'm Tanya Williams. I'm a physician and I've been practicing since 1993 in obstetrics and gynecology, and in the last 22 years I've been focusing primarily on infertility and reproductive endocrinology. So I see patients who are having difficulty trying to conceive, and a lot of those patients will have endometriosis, which we help them identify and navigate.
Hi, my name is Denise Campbell. I'm the director on the board of the Endo Network Canada. I'm also a member of the Endo Act and also a co-chair of the Endo Ambassador Program.
Hello, my name is Joanna Posidolo. I'm the pelvic health manager at Adelaide Health Clinic. I'm also a pelvic health physiotherapist and an orthopedic physiotherapist. I work with women with reproductive health issues such as endometriosis and uterine fibroids. And I also work with women experiencing pelvic health symptoms such as chronic pelvic health pain, low back pain, incontinence, and also pregnancy, labor and delivery, menopause, and beyond.
How have you been introduced and or encountered endometriosis, whether personally or through your work?
So I have encountered endometriosis through my work. As a pelvic health physiotherapist, I see a lot of patients who come in with symptoms of endometriosis, such as pain with sex or incontinence or with chronic pelvic pain. And because endometriosis mimics other GI issues as well as other gynecological issues, sometimes they're waiting for diagnosis. So in the meantime, I help and assist in alleviating symptoms of endometriosis.
I have endometriosis. I have been diagnosed in 2015, 2016. Had no idea what endometriosis was, what was it about, the symptoms, nothing like that until I was actually diagnosed. It's very difficult living with endometriosis. It's a chronic illness and it impacts your whole body. And every aspect of your life.
So my encounter with endometriosis is really as a fertility clinician. So patients come to see me, they're usually referred by their family doctor, sometimes another gynecologist, because their primary issue is subfertility. So during the investigative process, sometimes we will identify endometriosis. And that typically is from, symptomatology and physical examination and various tests. And then they're looking for a solution to help them get pregnant. And that's usually where I come in.
What are some of the ways that Black women diagnosed with endometriosis are impacted by it? So what are some ways that they're impacted by it? Maybe we can start with Denise. You can tell us a little bit about your lived experience.
Yeah, my diagnosis was at 35. So my lived experience in pain was, it was a roller coaster. I actually didn't have the typical pain of endometriosis of the heavy bleeding and long length of period. My experience when I was complaining to my doctor was chest pain.
Yeah.
So I said, I have chest pain, and I'm having difficulty breathing.
Yeah.
So my doctor recommendation was to exercise. So I kept going and asking, is there something happening to me? Because I don't feel well. I'm tired all the time, and I'm just having difficulty. Just like even walking, I'm out of breath. That's a little bit strange. So he still dismissed it, said, I think you just need to be more active.
Yeah.
So finally I got a pap smear, and the nurse asked me, actually first time ever, somebody asked me, how is your period? How is your cycle? What's happening with your menstrual cycle?
Yeah.
I was like, oh my gosh, thank you for asking. it's not going well. I'm okay, I think. Like, I do have some pain, but my main concern is my chest pain. And yeah, I just don't feel well. So she started to like just listen to my chest. And then she looked below at my stomach and she could see that it was very bloated. She felt around and she noticed that she felt a mass around my belly button area. So she says, you know, there's something happening for you. And I was like, yeah, I think so. I've been telling everybody. So she said, let's go get some x-rays. Let's do your chest. Let's do your abdomen. Let's just start with x-rays. So the x-rays came back showing that I had a mass in my belly button. I had a mass in my chest, in my lungs. I had a collapsed lung. I had fluid in the lungs. So that's when everything was going quickly. It was like every week, let's do this test. Let's get you to get a biopsy. But again, nobody mentioned endometriosis. Not at all. They didn't even bring up endometriosis or anything connected to menstrual pain or cycle or anything, even fibroids. Because I was like, oh, maybe it's fibroids. They're like, oh, no, I think it's something else. So that was my journey. They asked me to go to the hospital to get a biopsy. I went there, and this was December 26th. I'll never forget. And they asked me to stay. And I'm like, no, I'm okay. I don't have to stay. I'm not that ill. And I was like, why am I downplaying my symptoms? Like, why am I doing that? And I was. My mom was like, stay in the hospital. Where are you going? What do you have to do? So I stayed, and I was in there for a week. And they drained the fluid out of my lungs. They did the biopsy, and they said, you have endometriosis. And honestly, I even dismissed that because I was like, I've never heard of this disease, so it can't be that bad. Which is totally wrong. My doctors actually was very upset for me just dismissed it. And I said, well, doctor, everybody else dismissed my pain. So now you're telling me about endometriosis. I've never heard of it. And he really went in. He gave me a bunch of information. He connected me to a gynecologist, and that's where I started my treatment. But it was difficult. I would tell people, maybe it's Black women too, that it's just like, I could power through, I can go on, you know, I'm okay. It's not that bad. When I think about it, there was times that I was in pain and I was on the floor. And I'm thinking, how is that not bad? There was times when I couldn't breathe. Like I couldn't go anywhere. And I'm still dismissing my symptoms. So finally, when he said, you have endometriosis, I was like, okay, let me look into it for myself. Let me understand what this disease is. And that's how I actually got connected to the Endo Network Canada. And I have to say, the most difficult challenge that I had, that I was saddened by, is because when I Googled endometriosis, I never seen anybody that looked like me.
That's huge.
It hit me really hard because I was just like, what's happening? Why I have this disease? I don't really know much about it, but all I see is white women.
And there is something to be said about that, because when that was actually being researched, I think it was by Dr. Sampson in the 1920s, he actually said it was predominantly in well-to-do demographics, which at that time was Caucasian and white. So it dismissed a whole entire population of Black and other women of color at that point. So that's why and even to this day, that stereotype and that bias continues to perpetuate within research and within treatments and within everything else. So that's why we see a lot of people of color be underdiagnosed or misdiagnosed. And that stereotype of a strong Black woman, that is the most damaging.
It hurts us.
So many ways, so many layers. It is so complex, and sometimes we feed into it ourselves. So even in hearing your story, and like, I'm so sorry you went through that.
Thank you.
It made me realize what we have bought into as a society and what we feed ourselves in terms of having to present in a certain way.
Oh my gosh.
And how to carry on in a certain way.
Absolutely.
It's exhausting, to be quite honest.
So exhausting. And I think that's one of the main issues why, when I would describe my sharp stabbing pain, they looked at me and I'm coming from work, and I'm all dolled up and dressed up, and it's like, I don't think you're in that much pain. I remember even getting some medication. It was just like a handful of medication.
Yeah.
I'm like, okay, I'll try these, but I'm really actually having sharp stabbing pain.
Yeah.
Like, please believe me.
Yeah.
You're so used to putting on the brave face.
I
right?
am.
Yeah.
Absolutely.
And one thing I would say about extrapelvic endometriosis, which is endometriosis outside of the abdominal region, I find that it's actually very common once you are looking for it. So as an orthopedic surgeon as well, as an orthopedic physiotherapist as well, I see a lot of women with shoulder pain. And it's very cyclical. So they're coming in for shoulder pain, and if they're going for another physiotherapist, they get treatment, they feel pretty good. Then they're coming back the same time, the next month, with the exact same thing. And that sometimes gets misdiagnosed as rotator cuff pain, or like tendinopathies, or inflammation within that, without actually doing a deep dive in terms of like, let's take a look at your reproductive health. Let's talk a little bit about what that looks like. Let's track your symptoms. And I find like the most powerful thing is tracking your symptoms and having objective measurements. So when you do go to your healthcare provider, no matter who it is, you have objective measurements as in like, this is what I feel, this is when I feel it. And they can start to connect the dots quite easily.
It's true. Often when, if you can tell us that it happens every month when you get your period, it really helps with the diagnosis. Yeah, for sure.
Yeah, no, that makes sense.
Yeah, and I do find that within Black women specifically, there is a lot of stigma and shame. Well, let me rephrase that. Within women, there's a stigma and shame when it comes to reproductive health. It's very hush-hush, it's very taboo. So such things such as pain with sex, no one will really talk or discuss that specifically. Some things such as like periods and heavy bleeding, no one will actually discuss that they're flooding through their periods, or they have to get up at night in order to change their pads. Okay. And sometimes when you see your mother or your sisters have the same symptoms, within the family, that's considered normal. Yeah. So you don't actually know what is a healthy period and what's an abnormal period.
And what might be happening is that maybe you all have endometriosis,
Exactly.
right? Because there is a genetic component.
Exactly.
Yeah.
I know, I agree.
Yeah.
I don't know at this point anybody else in my family that has been diagnosed, but I think they just don't know, right? Or they just dismiss their symptoms, or I'm not even sure, or their doctors are not investigating, right? But right now, I'm like the only one, but I'm sure I'm not. Yeah.
But I think you make a good point. But in some cultures too, I mean, there isn't even a word for period.
No.
Like they don't have a word for period, so it's no one's talking about it,
At
right?
all. Yeah.
And it's true. I think doctors in a lot of cases are remiss in terms of not asking patients about their sexual intercourse.
Yeah.
And are you having pain with sexual intercourse? We don't ask that question sometimes because maybe the doctor's not feeling comfortable asking about it. Maybe the patient, maybe they anticipate that the patient isn't going to feel comfortable asking, talking about it.
Yeah.
So it gets skipped over, right?
And also there needs to be an aspect of cultural humility or competence as you ask certain questions.
Yes.
So the way that you ask it needs to be able to resonate with the patient in front of you. Otherwise, you miss a lot of opportunities to do a deeper dive into it. So as opposed to, is your period normal? Let's...
What is normal?
Yeah.
That's right. The patient does not know.
They'll be like, yes, it is.
I'll be like, sure.
Yeah, it is.
I think
Are
so.
you bleeding heavily? Yes, I am. Or like, am I bleeding normal? Yes, I am.
Yeah.
And then meanwhile, they're in a vat of blood, like at night. So it's one of those things in terms of like being able to categorize as a patient what you're experiencing objectively, but also as a healthcare provider, like how do you ask specific questions in order to get the information necessary in order to treat the patient comprehensively.
Now that we've talked a lot about the experience of endometriosis and how it may impact Black women, can we talk a little bit more about pain management? And how does someone with endometriosis manage that pain?
That's a fantastic question. And I think it's something that really needs to be dug into. So whenever I encounter patients with endometriosis, or any patient for that matter, I always discuss with them the pillars of health, which is sleep, nutrition and hydration, physical exercise, and then also their emotional health, or how they manage stress. So it's a very comprehensive way in terms of trying to understand where the contributing factors is, and also how we can start to help manage those symptoms. So sleep is so important and so integral in terms of healing responses, and in terms of being able to decrease some of the anxiety and some of the adverse or the negative symptoms of endometriosis. With physical exercise and stretches, getting air, getting some type of activity on a daily basis is so important in order to ensure that your well-being is actually quite optimal. And then in terms of nutrition and hydration, ensuring that you're not eating inflammatory foods, making sure that you are going within a diet that actually honors your culture, but also honors what's going on within your body, is going to be so important as well. And then,
have you heard about the macrobiotic diet for endometriosis?
Yes.
What are your thoughts on that?
I feel like with that, it could definitely assist with some patients, with some patients not as much. But at the same time, I really do believe that it depends on the healthcare provider and the patient, and working together in collaboration to make sure it works well for them. Yeah. What are your thoughts on it?
I see the potential benefits. I mean, it's basically sugar-free, gluten-free, dairy-free, right? So I see a lot of benefits there, but it's so restrictive. I think it's hard for patients to be compliant, right?
And then that bears in mind things such as behavioral change. Because whenever we're trying to give interventions, sometimes we're expecting a complete 180 degrees, and that's not fair to anyone.
Right.
In fact, you're actually setting people up for failure. So if we're trying to change behavior, whether it's like, okay, we would like you to increase your physical activity in some way, shape, or form, let's be realistic. Let's actually play towards your strengths. I'm not asking you to run a marathon, but if your thing is dancing, excellent. Let's take that. Let's work with that. Let's make that something that we can interweave and incorporate towards your day-to-day in a way that actually honors you. Otherwise, like, no, I'm not going to be running a marathon. No, I'm not going to be doing like 5 days of strength training, 1 day of Pilates. No, it doesn't really make sense. So I really want to meet patients where they are at in order to ensure that we're going towards the same place.
I think it's also true that when people start a program, they're gung-ho and they're ready to go. I'll go 1 hour, I'll go 2 hours in a day. I can do this. And then, of course, it doesn't meet your expectations. And you can't do that for the rest of your life because it's just too onerous. So it's better to go, okay, I can do 10 minutes every day, or I can do 15 minutes every day, right? And then you can be successful.
And then from that success, it gives you the confidence to be able to build on that.
To build on it. Exactly.
Otherwise, it's just going to be like, okay, I failed at this thing again, and then what next?
Exactly.
So like, I definitely don't want that for patients. And in regards to, in terms of like pain management, public health therapy is essential in terms of like managing endometriosis. But whenever I think of endometriosis and management, I really want people to think about it in a comprehensive way. So this means like, okay, your naturopath or nutritionist that's going to help you, your family MD and how they're going to work. And then we can't really forget about the psychological factors with endometriosis and the mental health impact that is associated with it. So like anxiety, depression, that's huge. And sometimes
very
like
high
very
with
high
people with endometriosis. It is.
And like sometimes I even think about patients who are in an intense state of grief for the simple reason that the life in which they pictured for themselves, they no longer have. So it's a change of identity in some way, shape, or form. So I really want patients to be able to have a psychotherapist or a mental health specialist in their corner. Because that's so important as they kind of guide through this process.
I know culturally sensitive also, and I like your approach because you're actually getting to know the patient. A lot of many appointments, it's just like, go out and walk. I was like, okay, but nobody, it's like, did you ask me
Yeah.
what I enjoyed?
Yeah. What if I hate walking?
Yeah, 'cause I do actually. But I actually like weight training.
There you go.
Has anybody asked
Yeah.
me that?
Yeah.
No.
Yeah.
Right.
It's
right.
just get exercise.
Yeah.
Yeah.
So if you break it down
Yes.
and get to know the patient,
Yes.
and that would be helpful, especially if we start with sleep.
Yeah.
That would be life changing.
Yeah.
But also with the expectations, because I thought when I had surgery, I'm just going to be a brand new woman. They're going to remove the tumor in my lungs,
Yeah.
in my belly button, and do the laparoscopic in my pelvic area. And I was just going to be amazing. And that was not the case.
Yeah.
That was not the case. First of all, I was off work longer than I thought I would be.
Yeah.
I even pushed to, again, the strong Black woman.
Yes.
It's okay, I'm going to go back to work.
Yeah.
And plus, economically,
It's hard.
endometriosis is quite expensive.
It's hard.
Because along with medication,
Yeah.
yes, and even pain management, physiotherapy, psychotherapy, naturopath, acupuncture.
Yeah.
If you don't have the benefits,
if you don't have
from
the
work,
benefits,
absolutely, it
it's
can be
Very
yeah.
It's
pricey.
very pricey.
Yeah. And like, let's not even forget the time or the finances from taking time off work.
Yes.
So that in itself is a financial endeavor as well. So
Yeah.
financially, endometriosis is expensive.
It is.
Like highly.
It's highly
Yeah.
expensive. And along with the physical pain, you also mentioned just the emotional pain. So the grief, like I had to go to grief counseling because I felt like my life is not what I had imagined it to be.
Yeah.
Right? It just, and even like when I would go to the gynecologist and she would ask, are you thinking about having babies? Do you want children? I'm like, how? Look at the state that I'm living in, right? And then I'm like, I'm not even thinking about that. I just want to be well, right? And it took a long time to get there, to figure out what is the right path when it comes to my health.
Yeah.
What works right for Denise,
Yes.
right?
And in the
You
stage of
know?
life that you're in
And
at
where
this
I'm
moment
in.
in time.
Yes.
Yeah.
Yeah.
Yeah, I think it's also you brought it up, but it's a huge deal when you
It is.
if you're the woman who pictures yourself with a family and then you find out
Yeah.
that it's not going to work,
gonna work.
it's not going to materialize for you through no fault of your own,
Yeah.
right? It does require a shift, right?
Yes,
it's
it
a
does.
big shift
Big
in
shift.
how you see yourself,
Yes.
and
Yes.
and that I think you definitely need to approach that with a counselor.
Yes, definitely.
Yeah.
Yes.
And sometimes, in terms of culture, being able to connect with outside providers, such as a mental health therapist, that in itself can be a little bit more taboo as well, or
Yeah.
stigmatizing. And having that construct of like, at this point in time, I should be doing X, I should be doing Y, I should be
Yes.
doing Z, that's really, really difficult.
It is.
And because in certain cultures, fertility is so highly regarded, not being able to conceive can be absolutely devastating.
Yes.
Yeah.
So true.
So being able to connect with providers that will help
Have
to
to.
guide through that is going to
Yeah.
be essential.
It
It's
is.
critical.
It's critical.
Yeah. So even if it's like, for example, like a church community,
Yes.
being able to speak with someone on the team that is culturally knowledgeable, but also medically knowledgeable,
Yes.
to be able to guide people through that is going to be so important,
Yeah.
and will be able to
Yes.
alleviate a lot of stress and a lot of guilt that
Yeah.
women may have, for the simple reason that, like you said, through no fault of their own, they cannot conceive. Yeah.
It's also difficult when, because I go to the church, I shared it with my family, shared it with my employer. You also, people who have endometriosis have to be prepared to actually let them know what the diagnosis is, what is endometriosis. So it's a part of education also, which I didn't realize. Like, I didn't know about it, but I didn't realize I'm in a community that had no idea what
Yeah.
endometriosis
Yeah.
was. So every time I had to explain, endo over and over again.
Yeah.
And the first thing was like, oh, so it's just a bad period? It's like, no, please don't even go there.
Don't reduce it to
Don't
that.
reduce it
Yeah.
to it's just a bad period.
Yeah.
Please don't even think of it like that,
Yeah.
you know, because that's when it gets dismissed.
Yeah.
Yeah, so many women have done that before too,
Yeah,
right? And then,
they have.
Yeah.
absolutely. Yeah.
So since we've had the opportunity to really discuss pain management, and we actually went into the next question. Yeah, which I think is really interesting that you guys kind of already brought it up. But can we talk a little bit about infertility and endometriosis and how it may impact an individual? And you guys already kind of started talking about this and the cultural implication as well.
Yeah.
But I would love to hear from Dr. Williams a little bit more about your work in this space and your interactions with patients who have to deal with this.
So just to return to the pain management issue, I wanted to maybe bring up some of the sort of medical aspects of the pain management, which I think probably, Denise, you would have been offered. Definitely, right? So I mean, typically we would start with non-steroidal anti-inflammatories like ibuprofen and ketorolac and
Naproxen.
Yeah, exactly, right? And for some women that works.
Yeah.
For others it's not enough, and so we would offer the birth control pill.
Yes.
That also it works for some, doesn't work for others.
Yeah.
It's also, as we know, contraceptive, so it doesn't really work if you're trying to get pregnant,
Yes.
right?
Yeah.
And some of the other medications, in fact, almost all of the medications that we use for endometriosis, unfortunately, are not great when you're trying to get pregnant, right?
No,
So
I can
progesterone
imagine.
supplementation,
Yeah.
or even what we call GnRH analogs, like Leuprolide
Yes.
and elagolix and those medications.
Yeah.
So they really just shut down your estrogen production,
They
and
do.
because as we know, endometriosis is promoted by estrogen, right?
Yeah.
So you can shut down estrogen production
Yes.
at the pituitary level,
Yeah.
and that helps with pain, right? It helps to decrease the size of the lesion, it helps to decrease
does.
with the pain,
Yeah.
but it doesn't help you to get pregnant.
No.
Right?
And what would you say are some of the side effects from those medications, specifically the Leuprolide? Yeah.
Oh
So
my
they
gosh.
typically make you feel menopausal.
Yeah.
Yes.
So headaches, hot flashes,
Hot flashes,
fatigue.
night sweats.
Yeah.
Yeah,
Absolutely.
it's difficult. Fatigue, just poor concentration.
Vaginal dryness,
Vaginal
yeah.
dryness.
Sometimes nausea,
Yeah.
sometimes
Yep.
cough,
Yeah.
sometimes
Yes.
bloating.
Bloating.
Yeah. So and you can't really use them long term either, because over the long term, certainly for 6 months or more,
Yeah.
there's bone loss, right? So
I
you have
know.
decreased bone density, which increases your risk of fractures. So
Yes, and even your teeth with
Yeah.
Lupron. So I'm experiencing that right now,
Yeah.
where I've had two of my tooth have fallen out.
Oh,
Oh my.
Yeah, just fell out.
Wow.
So
And you
now
think
I
that's
need
because of the bone?
bone.
Oh,
Yeah. So I know a lot of people don't talk about it, but
Yeah.
it,
The
No,
side
that's
effects are huge.
that-
Yeah.
It
that's
is huge.
definitely not something that we
Yeah.
talk about at all.
no.
And so if you're going to be on these drugs long term, you need to
Yeah.
do what we call add back therapy. So you
Yes.
add back a little estrogen, you add back a little progesterone.
Yeah.
That protects the endometrium,
Yeah.
just the lining of the uterus,
Yeah.
from getting cancer.
Yeah.
But it also is not enough. It's enough to take away those hot flashes, but not enough to make the endometriosis grow.
Yeah.
Right?
Yeah.
So that's sort of the next step if you're not responding to like just pain pills or birth control pills. There's some new things that are coming on the market now, and they're in phase 2 trials,
Yes.
like medications that we typically use for high prolactin. That's one of the pituitary hormones, and it's responsible for. I think the audience would probably be more familiar with that. That's a hormone that causes milk letdown.
Yeah.
So, like when you're breastfeeding, that would be elevated. But you can have that elevated for other reasons,
reasons. Okay.
not related to endometriosis. But there's a drug that we use to treat that that has shown some promise for endometriosis.
Oh, that's
and
good.
and it can, you know, decrease the implants of
Yes.
endometriosis, decrease the size of the lesions,
Yes.
decrease the pain associated with it as well. But they're just in phase 2 trials now, so we're getting there.
Yeah.
But for now, I'd say the majority of the medications, unfortunately, are counter to your fertility
Yeah.
goals.
And also short term, like you mentioned as well.
Yes,
Yeah.
yes. Yes, definitely.
And speaking about fertility, I know you're fantastic, OB-GYN. So what do you guys do for fertility as it pertains to endometriosis?
So sometimes patients come in already knowing that they have endometriosis,
Yeah.
and because
That's
they would have
good.
had a laparoscopy or something to determine that. But sometimes they don't. And so in the process of taking our history and doing our physical examination, we would get to the diagnosis for them.
Yeah.
So as you know, typical symptoms are painful periods, painful intercourse, especially with deep intercourse, painful bowel movements,
Yes.
painful urination,
Yes.
chronic pelvic pain, and that's usually for endometriosis that's confined to the pelvis.
Yes.
But as you know, it can be outside of the pelvis
Yes.
too, right?
Yeah.
And I think, Joanne, you talked about pain radiating to the shoulder,
Yes.
and that's
know.
classically, if it's endometriosis,
Yeah.
endometriosis on the diaphragm,
Yeah.
right?
Yeah.
Because it can spread. So
Yeah,
our
it
typical,
can.
you were talking about Samson's theory, those
Yes.
original studies,
Yeah.
and he was the one who sort of led us to the idea that it's from retrograde menstruation, right?
Yeah.
So the menstrual flow going
Backwards,
backwards through the
yeah.
fallopian tubes.
Yes.
But that's kind of only one way, because it doesn't explain how do you get endometriosis in your chest,
exactly,
right?
right.
So we can
So
we
the
can have,
tissues are moving, right?
yeah. So there's
Yes.
probably some other issues there.
Yeah.
So there's probably some lymphatic spread that's
Yeah.
possible.
Yeah.
There's probably some transformation of undifferentiated cells in the pelvis. And there's also this altered immunity theory as well, which, so in addition to that regurgitation of menstrual flow, your body is supposed to recognize that that's not supposed to be
It's
there.
not
and
supposed
it's
to be
supposed
there.
to chew it up and get rid of it.
Yes.
But in the case of women with endometriosis,
Yeah.
it doesn't, because
Yeah.
it doesn't
Doesn't.
respond. It doesn't see that it's not supposed to be there,
No.
and so it basically grows roots and
Yes.
and spreads and gets blood flow and it promotes
it's like
itself,
alive.
right?
Yeah.
Oh my gosh.
Exactly.
And that probably kind of leads to a lot of the inflammation and the adhesions.
Absolutely.
Specifically,
It
and
does.
especially like within fertility, just within the pelvic cavity, and kind of distorting like the uterus, the fallopian tubes, the ovaries as well.
Absolutely.
And also like maybe even blockages of those
Yeah.
as well. Yeah.
And
Yes.
oftentimes when we're doing our investigations, we'll identify that patients have blocked tubes.
Yeah.
I mean, there's a number of different reasons for blocked tubes, but endometriosis is one of them.
them.
Just the anatomic distortion from all that scar tissue, right?
Yeah. Yeah.
And then, not to mention, you mentioned inflammatory chemicals, those
Yeah.
biochemical
Yes.
substances that affect the way the egg moves, affect the way the sperm moves, affect the way
Yes.
it affects implantation.
Yeah.
There's so many different ways for endometriosis to affect your
affect-
fertility.
Yeah.
Right?
So what happens when someone comes to you and your diagnosis is yes endometriosis, but they also have like blocked tubes or ovaries are covered, and sometimes they have cysts and all these other things. Do you do surgery first and then you go like on these medications, and how long are these people going to be on these medications if they want to have a baby? I know everyone's going to
So,
be different, but
very good question. And it's controversial.
Yeah.
And a lot of it depends on what does your patient want.
Yes.
Right?
Yeah.
So if your patient does want to get pregnant, sometimes they want one child, sometimes they want two children,
Yeah.
3 children. So a lot of that will determine, what you offer.
Yeah.
How bad is their pain?
yes.
Is it, because I'll have patients who'll say, well, my pain is it's severe, but you know what? It's manageable. If I take some ibuprofen during my period, I'm fine.
They're fine, yes.
Right?
True.
And so they're saying, well, no, I don't really want to have surgery right now. And there is controversy about doing surgery first, because when you have to remove those cysts on the ovaries that are related to endometriosis, just by removing the cyst, you're also going to remove some good follicles, right? So you're removing good eggs. And so that decreases your ovarian reserve, and then that makes it makes your situation in some cases worse, right? So a lot of the times, and now this has become quite important, is we address the idea of fertility preservation with our patients who have endometriosis, even when it's not so severe endometriosis, because, for example, what your patient comes in and she's 22 years old, 24 years old. She has moderate endometriosis. She wants to have a family later, but maybe she's still in school. She's not really ready to get pregnant now. So that's something that we need to address is, should you be storing your eggs? Because you might want to use them later. And we know that women with endometriosis is progressive, so it goes from mild to moderate to severe. And as it becomes more severe, that affects the quality of your eggs and the quantity of your eggs. So it's probably going to get worse. So maybe she would be best served by, freezing her eggs now to give her an opportunity to have a child later. It's not a guarantee, of course, but it does prolong your fertility.
And gives you some options as well.
Exactly.
But that's why it's so important for people to know what endometriosis is, and to maybe get a diagnosis. Also see somebody like you, even if they don't want children at that time. But the younger you are and the more knowledge you have, you can make a better decision.
100%. And even knowing about your diagnosis of endometriosis before you start your fertility journey, your fertility treatment, does impact your outcome, right? Rather than finding it out later on, right? Because maybe we haven't used the right approach. And I think for women who are having those symptoms, rather than saying, oh, it's nothing, I'll be fine, maybe get tested. Because what if your tubes are blocked? Then it's futile for you to try to get pregnant on your own, right? You might be thinking, okay, I've been told that, because I'm young, I should try for a year before I seek help. But maybe you're not the right person to try for a year, because maybe with your endometriosis, you already have some anatomic distortion and tubal obstruction and all of that. So I do think it's important, if you're having these symptoms, you need to, ask the questions of your doctor.
I would also say as well that in some situations, people don't know they have endometriosis until they start trying, and then they realize that they can.
They come to see somebody like me, and then they find out, right?
So that is their first and only symptom of endometriosis, infertility.
Exactly. 20% of patients with infertility are asymptomatic, right? So they might not have any symptoms.
And then at that point in time, it becomes interesting challenge in balancing what that means to them going forward. So
life-changing.
It is very life-changing. So at that point in time, if someone didn't have symptoms of endo, their first symptom is infertility, how would you guys navigate that with them?
So again, I think it's all about, what are your goals, right? I think that has to be your first question. What are your goals? And, how old are you? And are you, what's your ovarian reserve like right now? Are your tubes open? Because if your tubes are open and you're relatively young, there are some less invasive treatments that we can use before we get to IVF, in vitro fertilization. So, for example, there are medications that we can use to make sure that you ovulate, and then do artificial insemination to try and get the sperm a little closer. And then sometimes, depending on how old you are and how much time you have, sometimes it helps to actually use one of these medications that suppresses your hormones
Okay.
initially to try to get to sort of minimize your endometriosis and minimize your symptoms, and then start trying. So, but a lot of it depends, because if you don't have time, it's different if you're 22
Yes.
versus
38,
38, right? If you're
39,
38, you don't
yeah.
have time
You
for
don't
that.
have time
Yeah.
for that.
No.
No.
So you sort of have to take it really is a gestalt. You have to take it all into perspective.
Yes.
And I think the most important thing is what does a patient want?
Yeah.
What are they looking for? And sometimes, as we talked about before, you may have to scale it back. And if you're 38 and you want 4 kids,
Yeah.
it may not happen. Right?
Or it may not happen the way you thought it would.
That's right.
So you could have 4 kids, but maybe they're adopted kids.
Yes.
Yes.
That's right.
Maybe it's
Yeah,
from
that's
surrogacy.
true.
Yeah.
So it's very much about expectation management, but also thinking creatively as well.
Yeah.
Yes.
100%
The
agree.
earlier
Yeah.
diagnosis is the best way that we go, right? So the doctors being aware and asking their patients, I know they might not even have pain, but maybe asking those questions about fertility and just letting them know some of the symptoms and like the longer you wait, in case you may have this disease, this is some of the outcomes.
Right.
Maybe getting because I think you can get just like your levels, right?
AMH
Your
levels.
AMH
Yeah,
levels. Yeah, you can.
Is that
you can do
something you could recommend to somebody, and would that link them to endometriosis if they have?
Not
They
really.
wouldn't.
No, but if it's very low,
Okay,
Then
that would
that
be an
might be
indicator.
A flag.
well, it might be a flag for
Yeah.
them.
Okay.
Yeah, and again, if they're if they would like to have a family in the
family,
future, using their own eggs or their own gametes,
Yes.
like then it might be something to think about. Maybe I need to be proactive in that
Yes.
regard.
Well, I like that idea of being proactive because at 38 and then you're diagnosed. Oh, that's hard.
Yeah.
No, so true.
That's
So
difficult.
true.
And I think this is where education is so paramount, because especially the way our society is going, where women are having children later and later on in life.
Exactly.
We really want to ensure that people have the information necessary in order to make informed decisions about their reproductive health.
Absolutely.
So even from high school,
yes.
what is a healthy period? What is an abnormal period? And then as people enter into the workforce, let's talk a little bit about family planning.
Yes.
What are your thoughts? Where do you see this going? And then they can decide at that point in time, do they want to consider egg freezing?
Yes.
Understanding that it's an option and not a guarantee, or is there something else or an alternative path that they need to do?
Yeah.
So I definitely feel like education is going to be key.
I think it's the most important.
Yeah,
So important,
I agree
Is
with you so
education.
much.
Yeah.
And I'm a big advocate for us doing more at the high school level.
Yes.
Yeah.
And especially early high school level.
Yes.
Yes.
I see so many patients who really don't understand how their bodies work.
At all.
No.
And so I think they're not asking the right questions,
Yeah.
and they're not being proactive.
Yeah. But just a basic understanding of your menstrual health.
Yes.
I think a lot of
It's
people.
huge. It's huge.
It is huge,
Yeah.
and a lot of us couldn't even describe it.
Yeah.
Yeah.
And
Right.
I definitely think it is a combination of different factors, for sure. And there is a lot of stigma and taboo just regarding
Yes.
reproductive health itself. Having said that, the onus and the custodian of your own health is you.
Yes.
Yes.
So
Correct.
you do need to have a proactive approach in terms of okay, what does my ovulation or menstrual cycle look like? Yeah. Like, how am I feeling month to month? Has it changed?
Yes.
Yeah. Like, does this interrupt my day-to-day living?
Yes.
Yeah. What do I want it to look like? And then going forward from there. Yeah.
But these are the conversations I have now, as an advocate, and I talk to my friends, and I ask these questions. Oh, you're so tired. Is your iron low?
Yeah.
Are you anemic?
Yeah.
Do you have heavy bleeding?
Yeah, yeah.
How long is your period?
Yeah.
are you missing school and work?
Yeah.
You know, but like now I'm asking these, I've never would have asked my friends, my girlfriends, any of these questions until now.
Yeah.
I'm all up in their cycle.
All the time. Yeah, for sure. And I think like with health literacy, it almost needs to be like on a year-to-year basis, like from grade 8 on. From grade 6 onwards.
Yeah.
I think grade 6.
Just like, okay, let's just
the
try
earlier
and
the better.
incorporate this into health curriculum, into syllabi, and then just make sure that people are aware when things go wrong. Oh, this isn't normal.
Yes.
This is because of this. Okay, I have an idea and an understanding.
I have an idea and understanding.
Yeah.
And where to go.
And where to go.
Yes.
Yeah. Because it is one thing to have the knowledge, but then how do you execute on that? Is that accessible to you?
Yes,
and when you get there, would they believe you? So like those are things that need to be kind of tweaked and kind of like understood so people can get the best help and assistance necessary for them.
Yeah, I mean, you bring up a good point too about when they get there, will they be heard?
Yes.
Right? And
You're right.
so I think it's true that there's a lot of mistrust in, you know, amongst the Black community for the healthcare process.
Yeah.
Yes.
And that I think that is changing. I hope it's changing.
Yeah.
And I think I hope it's changing based on the fact that there are more people. They're gonna see more people who look like them.
Yes.
Right.
Yeah.
Because that we're working on increasing that for sure.
Yeah.
Like in Canada.
Yeah.
So I hope that's going to change.
Yeah.
You know, with time, and that mistrust will diminish.
Yeah. And like you said, when people do look like them, the chances or the outcomes are more positive.
It is.
And are more effective. And at the same time, I do see that within the Canadian system, the process and the educational culture, humility and competence is being a little bit more focused on. So when people and when healthcare providers are now being trained, there is an aspect of cultural humility that's embedded and interweaved into their curriculum. So this means that yes, we're seeing people who look like you within the healthcare field, but also people who may not look like you. Hopefully they have the right wherewithal to ask the right questions, to understand where you're coming from.
Absolutely.
At the end of the day, once again, the onus is on you. So being able to navigate that system and ask the right questions is so important. So for example, what possible alternatives diagnosis could this be? What are the interventions? What are the benefits? What are the consequences if I don't do this?
Right.
What are the consequences if I do this? What are the side effects? And being able to track your symptoms and have objective measurements, that's so important because then it tells an entire picture.
Yeah, but we want people in their community. I think that's where it starts. We have to live in community.
For sure.
As much as what the onus is on myself, I learned so much as soon as I was connected to the Endo Network. That was my best education. That's like my PhD in endometriosis because they have lived experience.
Right.
Some of them were undiagnosed, some of them were dismissed. So we have support groups where we talk about our experiences. Our experiences are going to be different because especially with me with chest pains, everybody was like, no, I've never heard of that before. But that's good, right? So you could share that with somebody. We just have to talk about it.
Yes,
for sure.
Talk about it. Talk about your symptoms. Talk about your health. Every aspect of what's happening to you. Share it. Share it with somebody. Practice it. So that way when you go to your doctor, it's like, let me tell you, doctor, this is what I have. I went to the Endo tribe and they said for me to talk to you about this, this, and this. You know, I think it makes a difference. And you're a little bit more confident when you continue to talk about it. You think it's normalized. It's like, all right, everyone's talking about menstrual health.
Yes.
Right?
I always say community is the cure.
Yeah.
All the time.
Oh my
Like I
gosh.
would say that
Changed
forever.
Life changing.
And
saved me.
Yeah, and when you have a supportive community, then there's no lengths that you can't go and won't go in order to get what is necessary for you to thrive.
Yes.
You learn from each other.
You learn from each other.
Yeah.
You do.
Yeah. So in this day and age, like community is fantastic. It's great. And when people say it takes a village, yes, it takes a village, and sometimes you have to buy that village.
Yes.
Which is unfortunate. But when you actually tap into your community and that lived experience, and you're able to build and cultivate that community, powerful.
Powerful.
Huge.
And it held me accountable too.
For sure.
Honestly, because when I would go and I'm like, oh, talk to my doctor again about this. They're like, yes. Talk to your doctor and text me after what your doctor said.
Yeah.
I'm like, okay, I will, sure. Sometimes you don't want to go, honestly. There's many times where I didn't want to do the follow-up. I didn't want to do the blood work. I didn't want to continue to investigate what was happening to my body. I'm going to be honest. But when in my village, they were like, no, let's do it. Let's go to the doctor. Do you want me to go with you? And I was like, no, it's okay. But that push was there.
Yeah.
For Black people, I needed it. And I'm not going to lie. I didn't want to go.
Yeah.
I didn't want to hear another diagnosis.
Yeah.
Because with endometriosis, I find there's so many other diagnoses that comes with it. So that's when I found out I had cysts. That's when I found out I had fibroids. And then the list just went on. Then I've had another tumor called thinoma. It was just like continuous. I felt like every other year I had some sort of surgery or diagnosis.
There's a fatigue that comes
and
along
the
with that,
fatigue,
right?
it does,
Like just,
right?
yeah.
But my community, my endo tribe, they just kept pushing me, kept supporting me, just understood exactly where I was and what was happening. Yeah.
I mean, the whole idea is that you want to feel better.
I want
right?
to feel better.
Yeah.
Exactly.
Okay, well, this has been extraordinary. We are coming to a close.
Okay. Now I'm like all comfortable.
Not just yet. We have one more question. I want to know what call to action that you each have. It could be about anything for professionals, for patients, or what you think is important that needs to happen so that there can be a change. And it could be a change for infertility and endometriosis or just endometriosis. Whatever you think is important, whatever it is you're already doing, whatever you want to see done to support Black women in Canada. Like, what do you think what do you think we should be doing?
So in terms of like calls to action and what we can definitely do in order to keep this conversation going, we mentioned it all before, and for me it's so important. Education and empowerment through education is key. I do believe that we can affect so much change when people understand their menstrual health, when people understand what is abnormal, what is healthy, and ways they can navigate through that. And then from this, as people start talking, we can actually start to dispel the stigma and the shame and taboo that is surrounding everything to do with menstruation, with reproductive health, specifically for women and specifically for Black women in the community. Yeah.
Absolutely. Because I work for the Endo Network Canada, we receive funding so we receive funding from Health Canada Sexual and Reproductive Health, SRH, and we have a campaign called #NoEndo.
Love it.
So the first thing of no endo is a bad period is not normal. Like, just as long as you know that having a period that is like causing you to miss school, causing you to miss work, again, heavy bleeding, that's not normal, that's not okay. So it's definitely time to seek support and seek help. We also have another campaign for Act on Endo. This is where we're calling in the government because that's where we need change actually for
the policy level.
So we're calling on the federal government and the provincial territory counterparts to develop a national action plan specifically for endometriosis. So we call on the federal government to consult with Canadian endometriosis community. That's us. There's so many people with lived experience. Actually, 2 million people in Canada have endometriosis. That's a lot.
I'm really glad to hear that we have those statistics, because so often we don't have Canadian statistics.
Yeah,
And
it helps.
we have to use American statistics and then and then sort of extrapolate from there, right?
Yeah.
So this is great that we have Canadian statistics.
And I wish it was broken down too by
race.
By race, yeah.
The one thing that I realized was that in Canada specifically, endometriosis is a $1.8 billion industry. So just in terms of like the costs that is associated with endometriosis. So once I received that statistics, it really brought to mind how pervasive endometriosis is. So not only does it affect that person, but it also affects where they work, where their relationships, their social engagements. Like every layer and facet of life is affected by it.
10% of women.
It is.
Yes, 10% of women. Absolutely.
That's a big number.
Yes. And the average delay to diagnose in Canada is 5.4 years. So think about if you're 20, and it's just like you have all these symptoms and you don't even get checked out until you're like 30 because I want to have a child. And it's like, oh my gosh.
And there are some women who it's much longer, 20 years. We did a
20 years.
Fertility Matters did a piece recently. 20 years for her diagnosis.
That's insane.
Terrible.
That's insane.
Yeah. It's very sad. But on the national, hopefully we'll have a national action plan, and they'll connect with people in the community. We'll have people that will actually have a multidisciplinary approach, right? So similar to what you're saying with the physiotherapy, with the gynecologist, like everybody, a holistic approach where everybody's in the room and supporting this individual.
And having said that, like I do work in a comprehensive collaborative team with different disciplines who are focused on pelvic health management. So like within the team, it's like naturopaths, psychotherapists, pelvic health. We have chiropractors, we have osteopaths, and we also liaise heavily with OBGYNs, family MDs. So we don't want patients to feel alone or like they're falling through the crack, but we also want to honor the fact that pelvic health issues are multidisciplinary, and they require a multidisciplinary and even an interdisciplinary approach because it affects so many different areas of their life.
On that note too, patients need to know that it's appropriate to look for physiotherapy help. I don't think patients think about that.
No.
And if you see a doctor who's not aware, then you may never get to that, right? Which just someone never get to see someone like you, which is remiss really on our part.
And then people like you, who I completely send patients to in order to be like, okay, let's talk a little bit more about your fertility. Please go and see fertility specialists so they can talk about the next steps, what that looks like for you.
Yeah, I think, from my perspective, I so agree with you about education. It is so important, and the earlier the better. And I think we need to remove the taboos and not eliminate the conversation about periods and sex and pain and all of that. And I think women generally, we are so stoic, and we just take it on the chin all the time, and then just think that, well, I'm supposed to be able to deal with this. I'll manage, right? And so I think we need to maybe allow women, and I don't mean society, women ourselves too. We need to allow ourselves to look for help, and also to look for help early. And my hope is that women who have symptoms that are suggestive of endometriosis go and get help early, and discuss their fertility earlier, and because it might make a difference, huge, and a difference to who you are, who you become.
Before we end, can you share a way that people can get in contact with you, whether it be your website or your social media?
So people can contact me through the website. It will be at www.adelaidehealthclinic.com.
So my website, again, is www.drtanyawilliams.com.
You can contact the Endo Network Canada at endometriosisnetwork.com. Instagram, please hit us up on Instagram at endonetwork_Canada. Twitter at the Endo Network. We're also on Facebook, the Endo Network.
All right, thank you so much, ladies. This was wonderful, and I know there's gonna be so many people that take so much from this, so I appreciate your time. And yeah, have a wonderful, wonderful, wonderful day. Thank you.
Oh, yeah.
Thank you. All right, everyone. Now, this was an amazing episode. Thank you for taking the time to listen. Thank you for taking part in this amazing experience with us. If you want more information about any of the speakers or about MenoCare, you can check out our website at www.menocare.ca. You can check out our social media, Instagram and Twitter, our MenoCare app, and on LinkedIn and Facebook, MenoCare.